Open Share Tray นี่แน่เลยโอเคงั้นเดี๋ยวต้องเปิดสไลด์แป๊บนะคะเหมือนปีที่แล้วก็เป็นอาการแบบนี้อยู่แป๊บนึง ก่อนจะเริ่มโอเคเดี๋ยวสักครู่นะคะอันนี้เห็นไหมคะ
เห็นค่ะ
อ๋อโอเคมี full screen โอเคค่ะงั้นพร้อมไหมคะเริ่มเลยก็ได้ นักเรียนพร้อมไหมคะ
แค่
พร้อม
นี้
ค่ะ
เดี๋ยวพร้อมไหมคะหรือจะให้รอสักครู่ เปิดได้แล้ว
อาจารย์คะรบกวนส่งสไลด์มาในแชทบ็อกซ์หรือส่งผ่านอาจารย์มาได้ไหมอะคะ
อ๋อ ได้ค่ะ อันนี้คือให้ส่งตอนนี้หรือให้ส่งหลังเรียนเสร็จดีค่ะ
อาจารย์สะดวกส่งเลยได้ไหมคะพวกหนูจะได้จดระหว่างเรียนเลย
อ๋อ ได้ เดี๋ยวนะคะ ต้องแปลงเป็น PDF งั้นสักครู่ได้ไหมคะ
ได้ค่ะขอบคุณค่ะอาจารย์
งั้นเดี๋ยวพี่ต้องทำยังไงก่อนเนี่ย ต้องออกอันนี้ก่อน สักครู่นะสักครู่นะคะพอดีมันคิดก่อนเราจะออกจากแชร์อันนี้ยังไงปึ๊บเดี๋ยวนะคะปึ๊บโอเคแชทบ็อกซ์อยู่ไหน อยู่นี่ อ๋อ งั้นส่ง พอดีเขาไม่ allow ให้ส่งในแชทบ็อกซ์เดี๋ยว ให้ส่งเป็น PDF ไปทางอีเมลอาจารย์สุภาวดีได้ไหมคะ
ได้ค่ะอาจารย์
เพราะว่าพอดีกดไอ้ตรงแชทบ็อกซ์เขาบอกว่าไม่ได้เป็นเมมเบอร์ ก็เลย
อ๋อ โอเคค่ะ ได้ค่ะ อาจารย์ส่งมาทางเมลก็ได้ค่ะ เดี๋ยวอัปโหลดให้เด็กในไลน์
กำลังลุ้นว่าไฟล์ใหญ่ไปหรือเปล่า นะคะ ลอง1อันไปก่อน สงสัยสไลด์ VT มันจะไม่ได้แน่เลยเดี๋ยวนะคะ มัน70เมกอะค่ะ มันใหญ่มาก
อ๋อ ถ้าเรา อ๋อ
เป็นส่งทาง LINE ได้ไหมคะ
ใช้ Gmail อ๋อ
อ๋อ ให้ลองใช้ Gmail ใช่ไหมคะ เดี๋ยวลองดูนะคะ
ค่ะ ถ้าใช้ Gmail มันจะเข้าในอะไรนะ Google Doc หรือว่าอะไรอย่างเงี้ย ให้อัตโนมัติเงี้ยค่ะ เราสา
อ๋อ
มารถ
ได้
ดาวน์โหล
ค่ะ
ด
เดี๋ยวลองดูนะคะ
ค่ะ
ดูแบบ low tech มากค่ะ เคน่าจะไปทั้ง2อันแล้วอะค่ะถ้าได้แล้วบอกนะคะระหว่างรอสไลด์จะรบกวนถามว่ารุ่นนี้มีทั้งหมดกี่คนนะคะ
19 คนค่ะอาจารย์
อ๋อเดี๋ยวอาจจะแบบมีคำถามจะให้เรียกตอบหรือวอลันเทียดีคะ ถ้าเกิดระหว่างสอนมีเลขที่กันไหมคะ
มีค่ะ
ก็คือเป็นเลขที่เรียงยังไงอะคะเรียง1 ถึง 19อย่างนี้ป่ะคะ
ใช่ค่ะ1 ถึง 19เลยค่ะ
อ๋อได้งั้นเดี๋ยวพี่เรียก ขออนุญาตเรียกเป็นเลขที่ก็ได้นะถ้าเกิดไม่มีคนตอบนะโอเคอาจจะขอพูดคร่าวๆก่อนว่าไอ้ VT ค่า VT อาจจะมีเนื้อหาที่เยอะนิดนึงอะนะคะส่วนเรื่อง sinus node dysfunction จริงๆมันเนื้อหามันไม่ได้เยอะมากมันค่อนข้างสั้นอาจจะ spend time กับ VT เยอะหน่อยเพราะว่าอันนี้น่าจะมีเนื้อหาที่เยอะหน่อยแล้วก็มีรายละเอียดเยอะขึ้นนิดนึงค่ะเดี๋ยวรอสไลด์กันก็ได้ค่ะจะได้เริ่ม
สไลด์อาจารย์อัปโหลดลงไลน์กรุ๊ปนะคะเรียบร้อยแล้วอาจจะใช้เวลานานนิดนึงนะคะเพราะสไลด์มัน
ใหญ่มากนะคะ
ใหญ่มากค่ะพอดาวน์โหลดเมื่อกี้ก็ใช้เวลา
มันมี
นาน
วิดีโอด้วยพอดีไม่แน่ใจว่าตอนแปลงเป็น PDF มันออกไปสภาพยังไงเหมือนกัน
มันน่าจะความละเอียดเยอะมากเนี้ยค่ะอาจารย์เอารูปคมชัดมามันก็เลยมันทำให้หนักไม่เป็นไรค่ะโอเคค่ะอาจารย์เริ่มไปพร้อมๆได้ค่ะ
ได้ค่ะอุ้ยแชร์ผิดอันนะฮะผิดคาบเนี่ยนี่โอเคเห็นสไลด์แล้วใช่ไหมคะ
เห็นแล้วค่ะอาจารย์
โอเคก็งั้นขอถามว่าความเข้าใจของคนเรียน19คนเนี่ยรู้จักคำว่า VT หรือ ventricular tachycardia ว่ายังไงบ้างอะค่ะลองให้ความเห็นแบ็กกราวด์ของเราแป๊บหนึ่งได้ไหมคะ
อาจารย์คะพอดีว่ามีนักศึกษาประมาณ 2-3 คนที่เขาไม่ค่อยเข้าใจภาษาไทยมากนัก
ให้เป็นภาษาอังกฤษใช่ไหมคะได้ค่ะ
ค่ะ
โอเคค่ะได้ค่ะงั้นสอนเป็นภาษาอังกฤษหมดเลยนะคะ
ค่ะอาจารย์ขอบคุณค่ะ
ค่ะ so we are going to start the lecture today understanding about ventricular tachycardia so I want to hear what you think about ventricular tachycardia in your own knowledge background can you tell me a little bit you can volunteer yourself first and then if no one volunteer maybe I'll go by your numbers if that okay with you guys
Okay, ventricular tachycardia is a kind of arrhythmia in the lower chamber of the heart.
Okay, that's good. Anyone want to add anything else?
It is when the heart rate is greater than 100 beats per minute.
Okay, so that's good. We bring up something about the rate, whether it has to be over 100 or some other numbers. We'll learn about that later. Anything else? Maybe one more, and then we can get started.
It is mostly caused by myocardial infarction in the myocardium of the ventricles, Ajan.
Oh, okay. That's great. Great background. So some of the cause of ventricular tachycardia could be coming from, you know, the patient used to have myocardial infarction. That could be what we call substrate of the ventricular tachycardia. So you're going to hear a lot of time that I'm going to say about substrate. Substrate mean something that sitting in the heart, and then that can create circuit for ventricular tachycardia anytime. So we can talk about that later. So that's a really good start. So this is going to be my outline. I know people cannot really pay attention more than an hour, so I'm going to try to make it not over 1.5 hours, and then we can get some questions and breaks. And again, you know, you can stop me and then ask questions along the way if you want, to make it more interactive during the class. So our outline, you know, we kind of talk a little bit about what ventricular tachycardia in your own knowledge, and then we can start with that, and then we can start talking about the cause of VT, as one of your friends talking about the cause of VT, whether it's coming from substrate of myocardial infarction or not. So that's a really good start. And we can understand a little bit more about mechanism of ventricular tachycardia. The reason that you have to understand mechanism, because when we are going to see the patient that coming to get a treatment for ventricular tachycardia, especially in the electrophysiology lab, if you understand mechanism of each patient, that you can follow along the case, and then you can be a part of success of that case. And then definitely what you're going to have to expose to in the future will be electrophysiology study of the ventricular tachycardia. So we can talk in detail about that, and I can give you an example of the case, and then give you more of the picture of how you're going to see in the future about electrophysiology study of the VT. So what's a VT? Before you're going to start understanding any arrhythmia, I think you've probably been through the class talking about the normal conduction system. So maybe we can walk through this a little bit one more time. Anyone want to go through in each box with me here? What is the first box here?
It's
really
it's a node.
It's a node. Yeah, that's good. What about this one?
AV node.
AV node. Yeah, you can see. So what you can see, AV node is not actually in the middle of the heart, but actually is in the floor of the atrium. So it's really important structure. Whenever you go in the EP lab, you want to do anything, you want to make sure you don't damage an AV node. I'm not worried so much about SA node because it's sitting actually in epicardial surface of the heart. So it's really difficult to damage when you go in the heart. So this is what you have to be realizing, that is really important when you be as a team, and you know they do procedure inside the heart. You make sure you're not damaging an AV node, which is sitting in the floor of the right atrium. What about the branch here? What does it call?
Bundle of His.
Bundle of His, and then it's separate into
Left and right.
Bundle branch. Okay, yeah, that's right. Really good. Very basic, but if you understand this, and if we all understand this picture, we're gonna be able to understand the whole thing about the VT. Okay, let's get started. So that's kind of imply how we can understand an ECG finding. So when SA node depolarize, and it will make a wavefront in the yellow color here. The wavefront in yellow color called atrial depolarization. So you will never see an AV node activity. You're going to see only what the result of SA node depolarization. The result of that is actually called P wave. You can see P wave here. And then what you're going to look for, you look for a P wave vector, whether it's depolarized in a vector from the right and upper part of the atrium or not. I'm not going to spend too much detail about this because we're not going to do a basic ECG, and you've been through this before, and you know that people understand AV node conduction as a delay between atrium and ventricle, which is a PR interval here. And then ventricular depolarization, really important in this class because you want to understand how to interpret the VT, where it's coming from the ventricular depolarization. So the vector of the QRS will tell us where the VT is coming from. And then after depolarization, you will get relaxation of the heart, which is called ventricular repolarization. So that's kind of basic. And just to get some start, before we going to talking about VT, maybe we should understand a little bit about what can give you a wide QRS and what can give you a narrow QRS. If you have a normal conduction system, you conduct down the bundle branch, all the branches down at the same time. So at the same time, you depolarize both ventricle at the same time, you will have narrow QRS because it happened at the same time. It won't take too long to depolarize the whole ventricle. It take only just very few milliseconds. So it's gonna go really sharp QRS. But whenever you have a problem, for example, one of the bundle branch really not working well, you have to go down only one bundle branch and then the other bundle branch resulting in block. So you're gonna have to delay to go to the other side. So that's gonna cause wide QRS, that because of the one of the bundle branch not conducting really well. So that's another reason why, one of the reason why you will see a wide QRS, for example. So this, for example, this called narrow QRS tachycardia. Everyone agree that it looks pretty narrow, right? Because it's really narrow. So then when you see what's different from narrow, you will start to say that it's called wide QRS tachycardia, and you have to understand that there's could be many causes that can cause wide QRS tachycardia. We'll go through that in a little bit. So one of your friend saying that, you know, definition of ventricular tachycardia, whether it used the rate to be as a cutoff. Yes, you can use a rate. Some people may talk about rate of 100 or 120. And people also describe that QRS should be wider than 120 milliseconds. That will look as wide QRS. And if you use the term sustained ventricular tachycardia, that means you have VT that actually sustaining more than 30 seconds nonstop. We'll call sustained VT. So example, this definitely look wide at the beginning. You can see the QRS look initially sharp, and then at the later part is wide. This is really important as well. When you look at these ECG, I also look at every single part of that QRS complex. When you start with the really narrow, when you start with the slower QRS, that's give you a different implication. So in this strips, you can see very monomorphic, looking the same every single beat, and very regular. So it calls monomorphic regular ventricular tachycardia or wide QRS tachycardia. And I just talked about this in the previous slide, that if you have conduction down both bundle branch, you can end up having a really narrow QRS in this particular circumstance. And wide QRS could be from ventricular origin, which is VT, or bundle branch block phenomenon. If you have conduction down the AV node but have one of the bundle branch block, you can get wide QRS. Or the third reason you could have because you have abnormal accessory connection between A and V's. Anyone know about what syndrome can have this accessory connection? Do you know what name of the syndrome?
Wolff-Parkinson-White syndrome.
Ah, okay, very good. So it's called Wolff-Parkinson-White syndrome. You can have abnormal accessory connection between atrium and the ventricle. Why it's called abnormal? Because if you look at anatomy of the heart, when you look at the valve ring actually form from the fibrous tissue that's insulated. So that means you cannot have electrical signal conducting from atrium down the ventricle at all, except down the AV node in that insulated in the His bundle region, come down the septum like this. So you cannot have any area of the atrium that can conduct down the ventricle aside from the AV node area at all. But in some of the patients, they were born with abnormal accessory connection between A and B's. So what happened is, you can see here, if you have the fiber in black here, you conducting down the fiber, you ended up activating the ventricle in the abnormal area first. You activate here first. So it's look pretty asymmetrical activation instead of going down the normal pathway, activating ventricle at the same time. So in this black arrow, it will activate ventricle from right ventricle first to the left. So the QRS morphology on this activation, it's going to look almost like left bundle branch block-like pattern. So it's called WPW or Wolff-Parkinson-White syndrome. When you look at the QRS of that patient, it will look as left bundle branch block pattern in this particular patient with the right-sided accessory pathway. On the other hand, if you have this black arrow on the left side, so that means you have accessory pathway on the left side, you will look like having right bundle branch block ECG on that particular patient. So again, to summarize, YQRS, when you look at the YQRS patient, you can have ventricular in origin, you can have atrial in origin plus bundle branch block, or you are dealing with patient with accessory pathway connection. So these three really important to understand. Okay. So that's actually explain my next slide. Why QRS tachycardia is all not VT, because there could be these two as well. Okay. So most commonly, if you see the YQRS tachycardia, if you wanna bid, you can be winning of 80% of the time that it could be VT, but 20% of the time you can be wrong, because it could be an SVT or atrial in origin with aberrancy conduction. So aberrancy, that's mean bundle branch block during SVT. Or like I said, you can have accessory pathway connection that can cause YQRS. Actually, number 3 here, there's a lot of term that look pretty confusing, but actually it means that SVT conducting down this accessory pathway that can cause YQRS. So understand this slide, it brings you to this slide. Number 1, YQRS could be VT. Number 2 could be SVT with bundle branch block, or could be SVT that goes down the bystander type of accessory pathway as well. Any question at this point?
อาจารย์ค่ะหนู
ค่ะ
มีคำถามค่ะอาจารย์ใช้ pointer หรือว่าใช้เมาส์ชี้อยู่หรือเปล่าค่ะ
ใช้เมาส์ค่ะ ไม่เห็นใช่ไหม
ใช่ มันไม่ขึ้นค่ะหนูก็เลยสงสัยว่ามัน
อ๋อ พี่ต้องใช้เลเซอร์ใช่ไหม เดี๋ยวนะ ต้องใช้เลเซอร์พอยเตอร์ค่ะ เห็นหรือยังคะ
อันนี้ขึ้นแล้วค่ะ
โอเค Any question? If no, I'll just keep going. Okay. So I'll keep talking about the cause of YQRS, probably repeat over and over again, and then you probably will say, okay, I got it. So this another, kind of figure to show more visualization of what I just talked about. If you have a QRS-Y that originating from the ventricle, you can call ventricular tachycardia. But if you have any type of SVT that conducting down an AV node, but one of the bundle branch actually blocked, you can get YQRS as well. So that's called SVT with underlying bundle branch block. Or like I said, if you have the phenomenon called aberrancy. What aberrancy means, so you see, you look at this second figure and the third figure. What different is, one is a permanent bundle branch block and one is just physiologic bundle branch block. So that's mean, you know, our bundle branch block, the right or the left, they're not actually stronger equally in both bundle branch. Normally, what we see is the right bundle is actually a little bit weaker than the left bundle by its anatomy. I'm not going to go too in details, but there's a reason behind that the right bundle actually more prone to get delay when there's a very fast input coming in from the up chamber here to the down chamber. So we call physiologic right bundle branch block when you have really fast rhythm conducting down an AV node, but the bundle branch still not ready. So you can end up having an SVT with physiologic bundle branch block, but then when an SVT stop, you resume sinus rhythm, you're gonna get just a normal functioning bundle branch block again. So it's not a permanent bundle branch block. When you stop SVT, you get a narrow QRS during sinus rhythm. On the other hand, the second figure, when you stop SVT, you are going to get a sinus rhythm with underlying bundle branch block because you have permanent bundle branch block in here. So I'm adding another figure. So it's mean that you can have wide QRS tachycardia from VT, from accessory pathway, from underlying bundle branch block, or the fourth one is from physiologic bundle branch block called aberrancy or aberration. You can say anything. Okay. So there are 4 differential diagnoses. Okay. Oops, I can't advance slide. Okay. So again, over and over again, we'll talk about the cause. So VT, SVT with aberrancy, or SVT with accessory pathway or pre-excited SVT, or because you have disease in the ventricle itself that externally caused by something else. For example, you're getting some medication, you have electrolyte abnormality, or definitely if you have if you are on pacemaker, and that's because of you are pacing the ventricle from the abnormal site. Okay, so EKG features that favor VT. This for clinician or physician to understand that if that's a VT. So these are the feature that gives you a little bit of the clue that YQRS is more like VT rather than SVT with aberrancy with bundle branch block. So if you have a feature, number 1 is AV dissociation. So anyone understand that what is AV dissociation means in the VT? Anyone want to give a try?
They're not coordinated.
Yes, they're not coordinated. And can you tell that's mean who is slower, who is faster in this case?
Ventricle is faster.
Yes. So when you have ventricular faster than A that not associated and slower, so that you can diagnose right away. That's called VT. Or if you have a Y complex tachycardia with left axis deviation. So we probably know already that left axis deviation mean that you have QRS that positive in lead 1, but negative in 2, 3, or AVF. So that's kind of give you kind of very weird, strange axis. So that could be likely coming from ventricular in origin. So it's a key feature that we look for. Or when you have AV dissociation, so that's mean an atrium actually conducting at different rate from the ventricle, that could be causing what we call capture of fusion beat. Anyone understand what fusion beats or capture beat is?
It's like the A and B like feels kind of mixed together.
Yeah, the fusion means something mixing. That's right. So it's mean the atrium actually trying to conduct down the ventricle, the only way that atrium going to conduct down the ventricle is you have to go down an AV node, right? So when you have A in between the V that trying to conduct down an AV node, it will activate some of the ventricle down the Purkinje fiber that can fuse with the VT morphology. So that when you have some in between the VT, if you have some of the feature of the QRS that look a little bit different, you probably say that could be a fusion beat. I'll show you in a picture in later. And capture beats, actually, if you could capture the whole ventricle in between the VT with that A that dissociate from VT, so that you're going to create a narrow QRS in between the VT. So this really important feature to tell us that this is ventricular tachycardia with AV dissociation that could cause fusion or capture beats. Or some people, the last bullet here, some people are trying to say if you have the axis very concordant in the pericardial lead, you probably favor diagnosis of VT rather than SVT. Okay, example, you can see here the P actually trying to, indicate where you see the P wave that dissociate from the ventricular tachycardia. This fast rhythm with the YQRS here, it's actually the VT. And in between, you can see the P actually representing an A rate that really slower than the ventricular tachycardia rate. So it's called AV dissociation during ventricular tachycardia. And this is the same patient overall. You can see that the QRS axis actually not really weird axis that much. You can see left bundle branch block pattern, but inferior axis, not really left axis, but you see the feature of AV dissociation during Y complex tachycardia. So you can diagnose right away that this is ventricular tachycardia. In the patient that already has substrate, patient with underlying dilated cardiomyopathy. And this example of the capture beat in A, we show in here in the bottom part. You can see when you have P that dissociate from the VT that could capture mostly of the normal conduction pathway that cause really narrow QRS. In this sense, because we will call it as a capture beat. But if you have kind of mixture between the two, look at this B in the bottom strip here. You can see this B is actually more or less a mixture between this Y and the narrow. So we call this a fusion B. So when you see this feature, AV dissociation, you see capture or fusion beat, it can help you diagnose clinically that this patient has ventricular tachycardia. That's it. Okay, so clinician may use a lot of feature to trying to diagnose ventricular tachycardia. You can go through this garden varieties criteria. We're not going to go into detail, but I just want to tell you that there's some criteria out there that people are trying to predict that it is VT. As a clinician, the reason because we want to make a presumptive diagnosis that first, before we bringing patient to the electrophysiology lab to get an idea and a plan what we're going to do in the EP lab that day. So this more or less, you're trying to predict the VT from the morphology, from the features on a ECG, and then that can give you a little bit clue that this looks like more VT than SVT with aberrancy. So we already kind of give you a background of VT, why it's YQRS, and then we're gonna give you a little bit more of the background, the cause of VT in general. So like I said, external factor, for example, electrolytes imbalance, something that can affecting your myocardium can cause YQRS or abnormal conduction in the QRS. And one of your friend also mentioned about coronary abnormality, which is myocardial infarction can cause VT as well. Or you could have history of cardiac surgery in the past, and that can cause YQRS as well. Well, infection itself, it's really famous these days that especially COVID infection can cause what we call myocarditis. The patient can be presenting with really bad myocardial injury, YQRS. We just saw one case over the past week that comes in after a COVID infection with really bad myocarditis that can cause ventricular tachycardia as well. Other than that, pacemaker, or a lot of time, this is what we deal with. We don't know what causing it. We just go in the lab and find a spot or some area that can be idiopathic. It just happened there and we can take care of it. Okay, so that's kind of in general the cause. Next, what would be the mechanism when you go in the electrophysiology lab? What will be the mechanism of each VT? So when you have ventricular tachycardia origin, when we're talking about mechanism, that means you're trying to go in that origin and see how it comes out. So if it comes out because it's going around some of the small structure and going through the circle, we call reentry. Or it's actually originating from the foci that's smaller than a millimeter. So you could be dealing with just one focal tissue, what we call automatic VT. Or we could be having a circuit that's smaller than the reentry circuit, or maybe the same size as this automatic foci, but you could trigger it from you do program stimulation in EP lab. So we call it trigger automaticity. So looking at this mechanism VT, the only two VT you could induce in a lab, but automatic VT, you cannot. You probably have to give medication to trying to imitate circumstance that patient always have VT. For example, if they complain that they have VT during exercise, maybe when they come to a lab, we just give them medication that mimic patient exercise in the EP lab that probably can bring in some automatic VT in the EP lab. Okay. So this more like picture showing the circuit. If you have circuit of the VT in the circle that causing the VT, it's really easier to get rid of this VT, because you could get rid of the VT by targeting any part of the circuit here, and we can pick and choose which area we can target. And this patient usually have some history of underlying disease, for example, cardiomyopathy or previous history of myocardial infarction that can be a substrate that can cause reentry circuit around that slow conduction area or the SCA. For example, and this patient has myocardial infarction. You have patient with the scar area, multiple scar area. In between the scar area, you can play hide and seek pretty much. So the electrical activity will go in between the scar area. It will go and take some time in the scar area and then comes out and then go in a loop again. So this can create re-entry type of ventricular tachycardia. So our target is, when we trying to go in the EP lab, we'll find the scar area by looking at the voltage when we are mapping, and then we can find what we call isthmus, or the narrowest area that have slow conduction, and then we can target this area. We could be successfully helping that patient out from the VT. Automatic, to give more visualization, that coming from very small spot area, or the trigger, the same thing, the small spot area that you can target in the lab as well. Okay, so those mechanism and those understanding, any question? We're gonna go through the real case and then the common type of VT, and then after this, Any question at this point? Everyone still with me?
Ajahn, can you like explain about capture beat again?
Oh, okay. Yeah, I think I find the capture beats really difficult to understand, but I probably have to go back to the anatomy picture so you probably understand better. Or maybe I'll go to this focal VT picture here. Okay, so I'm gonna give you some example. So for example, the VT here going around, let's say firing at the rate of 120 maybe, and then SA node probably trying to fire around rate of 80. So SA node firing down to the rate of 80 beats a minute, and this 120 up. If SA node wants to conduct down an AV node to the ventricle, meaning you have to have the timing of SA node trying to penetrate this branch in between that VT. So between that VT or between that VT, if you could penetrate down and you can capture this first and depolarize myocardium first, so that you can stop VT for just one beat. So that means in between the VT, if you have really narrow QRS, that means you actually try to conquer the VT by capturing the AV node. Let me give you this picture. And then you probably have some ideas about this. So if you look at this VT, the timing of this VT is actually, it's beating at this rate, right? So going forward, it's supposed to go at this rate, but then it's supposed to come around here. But the A activity in here actually be able to capture an AV node and actually capture the myocardium first in the direction that coming down an AV node first. So that BT doesn't occur for one beat. So it's kind of stopped for one beat, and then the clock will start again that my next VT gonna come here. So it comes like automatic. But it doesn't come here again because of the ventricle actually follow command of the sinus node and AV node in this point. So the VT could not depolarize the myocardium. Does that give you a little bit more sense?
Yes.
Okay. ถ้าเกิดภาษาอังกฤษไม่รู้เรื่องเดี๋ยวถามภาษาไทยใหม่ได้นะ มันยากนิดนึง All right. So I'm going to give you, this is going to be more relevant that you're going to see when you come to our EP lab, and going to be more practical that you're going to use in the future. But if you have really good foundation of the background that we just talked about, it's going to make you understand a little bit better of where the VT coming from. So the common type that you're going to see in EP lab, you know, there's garden varieties of VTs. The most common will be outflow tract type of VT. The outflow tract, we're talking about right ventricular outflow tract or left ventricular outflow tract. Or left ventricle VT. We see, if we remember the fascicle on the left bundle branch, there's like the fascicle like branching, really small branching all over the left ventricle. So that can create the re-entry circuit in between the left ventricle. And most commonly, we see one of the fascicle can create the re-entry circuit. You know, if you go back to this picture, you can see the left ventricle have the left bundle branch that really goes into small little branch. So it's enough. This could be a substrate for re-entry circuit around the Purkinje fiber here. Most commonly, we see around the left posterior fascicle. And sometimes, actually, very recently, we have a patient that have re-entry circuit around this fiber that could be taken care in a cath lab as well. So outflow tract VT or LVVT, or the last one that we talked about, patient with underlying scar that could cause a reentry type of VT as well around the substrate area. So localization give you a little bit just kind of ballpark area, ballpark idea that if you have ventricular tachycardia that has QRS morphology with the right bundle branch block morphology, that means you originate VT originating from the left ventricle. You're gonna have more delay conduction down the RV. So your ECG feature gonna feature right bundle branch block pattern. So what's right bundle branch block pattern mean? You're gonna have upright QRS in a V1, which sometimes you can have maybe fractionate upright in V1 and Y QRS in V1. On the other hand, if you have more upright QRS in V6, and sometimes could be a fractionate or rapid ears pattern, so that's you have VT coming from the right ventricle. So it's give you kind of opposite feeling when you have LVVT, you're gonna have right bundle branch block pattern morphology. If you have RVVT, you're gonna have left bundle branch block morphology. In exception, if for LVOT, left ventricular outflow tract, you probably could have a pattern of the left bundle branch block. The reason because if you remember the anatomy of the aorta actually hiding behind the pulmonic valve and actually kind of cross a little bit backward to the right of the pulmonic valve, which is over here. We'll show in the picture later. And that LVOT VT can cause left bundle branch block pattern as well. Okay, and you're probably familiar with this lead ECG. Really important to go back and trying to get used to, which lead, where exactly it is, because if you want to understand the vector of the VT, where it's coming from, you have to be able to memorize this is where the lead is. So the frontal plane, lead 1, 2, 3, and this augmented lead can give you an idea of right, left, and superior and inferior, right? And then the chest lead, on the other hand, can give you more or less anterior, posterior projection, whether it's coming from posterior or anterior, can give some ideas, and also with left and right projection as well. Okay, and this trying to give you a baseline QRS, normal axis mean coming positively in the AVF with the narrow QRS, and normal force you see more upright QRS in the V6 more than V1 because more force you see in the left ventricle. So this is a normal vector of the ECG. Now we're going to go through some example, and anyone want to volunteer? This Y QRS tachycardia has which bundle branch block pattern on this ECG? Anyone want to give a shot? So this particular ventricular tachycardia has Y QRS, right? And we talk about bundle branch block like pattern that we're going to tell you where this VT coming from. Is it right or left bundle branch block?ยังอยู่กันหรือเปล่า
left bundle branch
Left
block
bundle branch.
Good. So remember when V6 really higher than the V1, so we call left bundle branch block. So you want to bet where it's coming from, the left bundle branch block?
Going from the right, upright.
Okay, so when you say upright, so you look at the AVF, right? The AVF actually has positive force, so meaning it's coming from top to bottom and then right to left. So if you want to bet, it could be any outflow tract, because if you remember the outflow tract, we talk about outflow tract, RVOT and LVOT actually lying on top of each other. You could have RVOT or LVOT origin. But some people kind of describe the precordial looking. If you have really positive force in V1 across to V6, so that's mean you're probably dealing with the foci that really coming from posterior structure. Remember which one is posterior, right ventricular outflow tract or left ventricular outflow tract? Which structure is more posterior?
LVOT.
Right or left? That's right. So this, if you want to bet, this would probably coming from LVOT VT. Is that easy? So more positive force, that's more, put you more L than the R. Great. See, you are so good now. Okay, now it's a little bit more challenge. The lead actually this V1 down here, V6. So this is actually VT. It's right bundle branch block or left bundle branch block?
Right bundle branch block.
Very good. Can you give me a reason? Or you kind of flip the coin? Your answer is right. Can you give me a reason why you say right bundle branch block? Ddao.
Because like V6 is not very high.
Good. That's one thing. The other thing, remember, which leads is wider. So V1 is actually wider, and with the QRS that kind of fractionate or rabbit ears looking here. So right precordium is more having really fractionate looking and wide. So that's probably delay to the right. So where's the VT coming from?
V3.
Say it again.
Does it coming from the V3?
So LV or RV?
LV.
That's correct. So it's coming from LV. So this is LVVT, one of the LVVT. And it's coming from actually the bottom part. So the bottom part means posteriorly. So it's actually coming from posterior fascicle re-entry circuit around posterior fascicle of the left bundle branch. Great, you guys are so good. So this is a picture that I just talked about. The RVOT actually lying anteriorly. Actually, look at this. The RVOT actually more leftward than the right LVOT. It's kind of weird. You're talking about, oh, it's RVOT, but actually it's anterior, but it's kind of deviate more leftward than LVOT is actually hiding over here. So sometimes you have to really understand correct anatomy to understand why the VT has that morphology. I just talked about this. If the left ventricular outflow tract, you have more origin from the more posteriorly. So what is more posteriorly mean? If it's more posterior, you're going to be able to give all the lead here positive force. Well, most of the lead more positive. So we can say it's early transition, meaning when we say early transition, mean you see flip QRS from negative in V1 become positive in V2, V3, 4, 5. But with the RV outflow tract, sometimes you can see really negative QRS in the V1 across to V3, and then you start seeing a flip axis again later. So we call later transition. So it's RVOT has more later transition than LVOT. This is more detail. If you don't want to memorize this, that's okay. But if you understand this anatomy, we'll be able to understand what we are looking at the VT origin when we are in the EP lab. All right, let's go through this. Which bundle branch walk pattern on this ECG? Left or right?
Left bundle branch.
Very good. And the transition, you see transition, is that which area? Between V2 and V3. So you see negative here and you see positive QRS here. So that's kind of not too late transition. This could be coming from either LVOT or could be RVOT in posteriorly. Okay. Just kind of give you an example of those transition things. So there's another one with left bundle branch block pattern and with transition at V2, V3 as well. So same answer as the previous one. Okay, this one is the same one that we just talked about. Very early, what we call concordant or super early transition. So it's from very posterior structure, LVOT. This one, where's the transition? Between which one? Do you see it's really blurry a little bit. So you see transition between V3 and V4. See, V3 is negative, V4 is positive. So that's later transition. Probably this coming from?
RVOT.
Very good, from RVOT. And what else you see on this ECG? You see the QRS look narrow here. What does it call here? See one of the QRS narrow? What does it call? I'm testing your recall memory.
Capture B.
Is it capture?
Very good. Either fusion or capture. Very good. Good job. Okay. So next we're gonna go through some of the EP study case. You wanna take a break or you wanna keep going? We can take like 5 minutes break if you want. You guys still okay? If you guys still okay, we'll keep going.
Keep going, Avatar.
Okay. All right. So EP study that we're gonna see. I'm gonna give you some example of these later. We're gonna see example of how we perform EP study in those VT case. And sometimes you're gonna see what we bring to the lab. It's not a VT, but actually kind of friend of VT, what we call PVCs. Or in a patient in particular disease called Brugada syndrome, we'll bring that patient to try to induce ventricular tachycardia in the EP lab as well. So I'm just gonna run through some really fun strip. So when we see this strip, we're gonna say a fake VT, which is artifact, for example. This one is actually not the real VT. It's too non-physiologic. You see the rays too fast and non-physiologic looking. This one as well, when you have almost look like VT, but actually your pulse oximetry is actually coincide with just the QRS here. So it's a fake VT as well. We call artifact, called fake VT. That's coming from anything else. Okay, so EP study for VT or VE, indication for patient that has ventricular, to induce VT or VF in a cath lab, and plan to do ablation in particular cases. So STIM protocol, I think you probably have some people teach you about how to perform program simulation in EP lab. Particularly if you want to induce ventricular tachycardia, you're going to do basically ventricular pacing. So the protocol that you can use overdrive pacing, you can do burst pacing, or you can do ramping, or you can do what we call extra stimulus testing, meaning you put in early PVCs in every single beat, trying to stimulate, try to initiate the reentry type of VT or trigger type of VT in the lab. And you can use medication to add on if at baseline patient you could not induce anything, to use this medication to help enhance the chance to get the ventricular arrhythmia during EP study. This is kind of give you a protocol that we use in the EP lab. Sometimes we paste from many sites in the ventricle, and when we do a stimulation train in ventricular extrastimulus training, we use different train many times. And you can add PVCs, maybe 1 PVCs or maybe 2 PVC. But just to give you a warning that if you give more PVCs and more aggressive train, even in normal healthy young individuals, you can induce ventricular fibrillation, but that's gonna give you more false positive result. So just keep in mind, you can be aggressive in terms of inducing the VT, but not too aggressive. Otherwise, you're gonna get something that you don't wanna get. Okay, and whenever you're gonna do ventricular VT stimulation or VF stimulation protocol, you have to make sure your defibrillation is ready. I do have experience in one case that I've seen that they trying to induce VF and ended up when VF occur, we were not that too surprised because we know that that patient had history of almost having cardiac arrest in the past. However, when we start VF in the cath lab that day, we just learned that our defibrillator that's not working. So it was really really too excited in that day. So you have to make sure that your defibrillator is on and ready to be used. Otherwise, that procedure could be a nightmare procedure. Example of the patient that we induce ventricular fibrillation in the lab. So you're trying to induce by train of ventricular training and then give the PVC. This one we give extra PVC of 2 beats, and then you can initiate ventricular tachycardia, ventricular fibrillation. So at the end, you have to have a defibrillation ready to be able to get the patient out of the VF. Okay. So example, you get the V stem and then you initiate the polymorphic VF. Really scary because if you could not defibrillate patient can die. You may end up have to do go to the route the CPR in the cath lab. Okay. And this is a patient that we already induced VT. So I'm give you kind of overview here. This is a tracing of the EP lab. The top 4 line is an ECG that kind of blown up a little bit because you make the speed go really fast. And then this CS, meaning the catheter is actually in the coronary sinus. And this is a catheter in the RV, and this catheter in the his area, and this is ablation catheter. So what do you see in the CS here? What do you see? What do you see this signal in the CS?
Atrial signal.
Yes. And what's in relationship with the V? What do you call this?
Their dissociation.
Very good. So AV dissociation would be faster than A. So that's typically you induce ventricular tachycardia. That's good. VA dissociation. And we look at this, it's kind of blown up, but actually you have Y complex tachycardia with right bundle branch block pattern. Okay, this is another one. Probably really harder to see, but if you look at the A signal here, we have A signal in the his catheter. The A is also dissociated from the V, and A is slower, so it's meaning you already induced ventricular tachycardia in the lab. So when you induce it, you understand what it is. You want to try to target it, and you want to try to get rid of it. So you have tool and a lot of things to use to map this VT, where it's coming from, and you're trying to get rid of it. So the very easy way to understand, to map the VT, first you have to understand the baseline of the patient, whether you are dealing with focal or you dealing with re-entry type of VT. For example, if you have patient with cardiomyopathy with the scarring, you're probably dealing with re-entry type of VT. So you have to also map the sequence of activation of that VT and also look for the substrate, which is scar, while you do a map during that VT as well. But with the focal, sometimes you see in just normal heart. So you just go right to map the activation sequence of that VT. What's the activation sequence mean? So it's mean that you have a catheter in the heart. One of the catheter could be a reference catheter, and then you just kind of measure the timing of that VT in reference to the other catheter. And then that's kind of give you kind of sort of a number, whether you are close to the circuit or not. And then you'll be able to identifying where the VT is coming from, and you can do the job to ablate it. Or in the patient that has really poor hemodynamics when you already start that VT, when they have really poor hemodynamics, you could not start that VT that often, because every single time you start that VT, patient has no blood pressure. So you ended up identifying the VT that you are initiate. You have the morphology of that VT recorded, and then what we do, we put the catheter in different areas, and we paste in each different area of the heart and see which area we can match the 12 leads ECG. The most matching, that means you are closer to the area that VT coming from, what we call paste mapping. So the technique of mapping VT in summary could be activation map, or could be a paste mapping as well. So paste mapping you use in patient with poor hemodynamics during VT. And this substrate I already talked about. When you want to do activation sequence mapping, if you are dealing with patient that probably substrate, you should be able to identify the substrate along the way that you do a mapping as well. Okay, for example here, we use 3D mapping to identify the voltage. We are actually do voltage mapping in this patient right here. And the area that has really good voltage, you can see in this bar over on the right hand here. If you are having a pink color, purple color, you have really good, healthy muscle tissue. You have really high voltage tissue. Very low voltage depict in a different color. In this company, they use the red color. So you have to learn which 3D mapping in each company, which one that they use, but it's actually sharing the same ideas or fundamental. Okay, so we know we've been through this EKG before. So this VT has left bundle and inferior axis, so coming from high, and could be coming from RVOT or LVOT because the transition V2 to V3. Okay, so give you a little bit more picture. If you go in, you see that ECG at the beginning, you want to go in and try to map the right ventricle first. If you find the right ventricle really early, you will try to ablate in the right ventricle first. And you know from this ECG that it could be coming from the left outflow tract as well. Meaning if you're trying to ablate or trying to map on the right and you couldn't find the early spot, so that's mean you know right away that this VT could be coming from the LVOT. So you will change your interest to the other site, which is LVOT as well. Okay, just kind of go through this. PVCs also has shared the same idea as looking at the morphology of the PVC as well. So in this patient, PVC has left bundle branch block morphology, and transition is actually V2, V3 as well. So that's PVC probably coming from somewhere along the outflow tract area as well. So you use PVC and VT ideas, actually sharing the same thing when you look at the QRS morphology. So in this patient, the VT actually was mapped. In this patient, I'm gonna give you kind of idea. This is anterior, this is posterior. This is actually right ventricular outflow tract that we create the geometry during a 3D mapping. And then we found very early spot over here at the posterior part of the right ventricular outflow tract. The ablation catheter that we use, we typically in the ventricle, we tend to use irrigated catheter. You probably heard about different type of catheters, and if you have the catheter that has the water coming around the lesions, you probably can cool the lesion, cool the area around the lesion. That means you can give a deeper energy down to the muscle or myocardium. So that's going to give you a better permanent and a lesion that can cure the ventricular tachycardia. So we'll just usually we'll just go right to the irrigated catheter when we have to ablate in the ventricle. Okay, not only knowing how to map, but in some case, when you bring the patient to the lab and you could not induce any VT or PVCs, normally because of some other factors. For example, you give sedation to the patient, you give some medication, you have to make sure those wouldn't affect your ventricular activity. For example, if the sedation is too heavy, that could be suppressing the VT as well. Okay, now I'm gonna just go through the case and probably give you a little bit more excitement of what we do in the real world, okay? All right, so this is a patient, a 10-year-old girl. She comes in with heart failure, pretty much. She comes in with this right bundle branch block morphology and superior axis, which is what you've seen before. This VT is coming from LV because of right bundle branch block. So I'm just gonna give you an answer. Same thing, almost the same as that patient. This one has the same morphology of right bundle branch block in V1 here, and superior axis coming from left ventricle somewhere posteriorly. Okay. So we identify probable site from the ECG. So we bring patient to the lab. We go right into, show you the picture here. We go right into aorta, and then coming down the aortic valve, go down to the LV. And then we mapped the area along the septum and more posterior. And during VT, we turn on an ablation, and then we get some automaticity from that VT a little bit, and then we're able to terminate that VT during an ablation. And you can see we mapped those area. This is an ablation catheter. We mapped the area that actually VT originating from. So it's really early on ablation catheter here. As you see the timing really early is coming at this catheter first. And then you also see the VA dissociation very clearly on the CS catheter here. So A pretty slow, but B is really fast. So that's so this 3D mapping in the same patient, you can create the geometry and you can minimize the fluoroscopy, and then you can understand the area that you map in a 3D picture. And then if you want to go back to the same area again, it's give you more precise location. So this case really very interesting. I just went to do an ablation on this patient actually last week in Chiang Rai. So this is a 14-year-old monk, comes in with history of heart failure for like 2 months, feeling tired, feeling not well. You can see X-ray show the heart humongous, really big. His first echo, you can appreciate here, very poor contraction. So he actually got admitted for a month ago in Chiang Rai, and he actually had thrombus in the left ventricle. At that time, we were worried that he would have a risk of the stroke as well. So we trying to anticoagulate to get rid of the thrombus first, and then we cannot do anything at this point. He also has the same type of tachycardia, which is right bundle branch Y complex, right bundle branch block, and superior axis. So same left ventricular VT. And you can see here the capture beat here as well. So this definitely VT as well. So he's in VT all the time. And finally, after 3 weeks in the hospital, he went into cardiac arrest. And then we decided to flown in Chiang Rai and then to trying to help him. So he's also on intra-aortic balloon pump just to help him with the blood pressure. He intubated already, so we brought him to the lab last week, and this is the EP lab. And then we are preparing the patient, and then during the case, you can appreciate that he's already in ventricular tachycardia with AV dissociation seen in the CS catheter here. And then we found really early spot, really nice spot. Putting the catheter there terminate the VT right away, so we put on the lesion there. And we tackle, because he has intra-aortic balloon pump in the aorta. If you remember the last girl we did down the aorta, down the aortic valve. But in this case, he already have the balloon in the aorta. So we cannot go back to the aorta again, probably more difficult. So we decided to do what we call transeptal puncture. So we go in the septum, puncture with the needle, and then put the sheet into the left atrium. And then we use the ablation catheter and then be able to find the spot of the VT and be able to terminate it. So there's a lesion in the LV and create the lesion over here. We don't have to do ablation like a really wide spot because these areas very small. Like I said, it's a millimeter area. You just have to be able to find it only. These are the Purkinje signal that we made the tag here. It's just to give us kind of idea that how the VT circulating. So actually the VT is probably going down one of the slow conduction area and going up here like a re-entry circuit. So we just cut off one of the part of the circuit here. So good news. You can be the part of the people that in the lab and help us to help these patients. So he, after ablation for 3 days, he was able to get extubated and he already went back to to home or temple. I'm not sure. Yeah, that function already looking better the next day. All right. So that's a 2 case of LVVT. This is an example of the case of patient with underlying heart problem that comes in with VT. So this patient will have Epstein anomaly, comes in with ventricular tachycardia, really wide QRS here. And you can see more or less really late transition. So it's coming from right ventricular area and coming from RV apex rather than outflow tract because negative in AVF vector here. So when you look at the VT here during the lab, you can see almost negative concordant in the precordial. So give you more negative, meaning you have to come from really anterior, which is RV. So this patient has really bad hemodynamics during this VT. So what you can do for the map this VT, instead of mapping during the ventricular tachycardia, you probably have to do pace mapping instead, or do substrate mapping and then target the substrate instead. Because during the VT, patient had no blood pressure, ended up with needing defibrillation during that VT. So what we did, we went to find the substrate. You probably look at this and may be saying that what we are looking at, is that a noise or not? But actually it's not a noise. It's actually the area that has scarring area, very low voltage and very fractionated area. So these are the signal that we're trying to target. So it's going to be like a, like a bombing a little bit. You identify the substrate of the scar and you're trying to close up the scar area that has potential area that could cause a re-entry circuit of the scar. So homogenize the scar, that's pretty much we can use that. And then this patient, we try to reinitiate again after trying to ablate the substrate and look like we be able to get rid of the VT after ablation. So you cannot induce further VT anymore after ablation. And again, what we did, we trying to identify the scar, and then between the island of the scar, that's the area that could cause a circuit of the VT, and you can ablate around the scar area as well. So another case with VT, and this one has left under branch block and inferior access, so from outflow tract. But this one, you can see the transition is totally different from the previous case. This one is very positive in all precordium. So that's coming from very posterior. So that's right. This one actually coming from behind the outflow tract on the right, but actually really posterior structure. So again, I talked about pace mapping in the patient that you cannot sustain the VT during mapping because you're going to have really poor hemodynamics. So what you're trying to do is you're trying to pace the area that you're interested on the ablation catheter, and you're trying to match whether this QRS actually matching to your VT template or not. And nowadays you have the template of the VT here. You can use the computerized software to try to match, and it's just going to give you a % of the matching. It's really easy. I always tease people in the EP lab that now we're going to do all the case. We don't have to use our brain anymore. You just have to know how to work around the software. Then you can get through all the case pretty much. So you're going to pick and choose the area that you get the really perfect match, and then you're just going to go right after that area, pretty much. For example, this one VT here, and then perfect match. You can see QRS on the right, almost identical to during the VT. So that's probably the area that you want to target. Okay, summary. So the whole 1.5 hours here, probably almost 2 hours, 1.5 hours, you probably want to make sure you understand anatomy and conduction system. And remember, we talk about VT mechanism and the prediction of the VT from ECG prior to coming to the case, and then that's going to help you do an ablation on each case. And when you are in the case with the patient with substrate, so you have to understand that which patient you have to find substrate or which patient you don't have to find substrate during that VT ablation. Okay. All right, we probably cover all the bases of VT. I'm sure that when you go, if anyone interested to come to the EP lab, probably cover pretty much all the bases that you have to know when you come to the EP lab. Question before we take some break. Anyone still awake? มีคำถามไหมคะ
Ajahn, can you explain the case again about the monk one?
อ๋อค่ะ Any question in particular, or you want me to go through what happened again?
Yeah, I think it was a bit too fast for me.
Oh, too fast. Okay. Yeah. Okay. So this one, an example of people like us can help the patient that really sick sometimes. So this is example of the one of the patient that comes in heart failure. So he probably sustained having a very sustained VT for 2 months. So it's long enough to get the heart fail and really dilated, and end up with his heart just kind of gives away that I'm just gonna die. So initially when he comes in, this is how his echocardiogram looked like. You guys familiar with this view, right? Everyone knows echocardiogram picture. So this is a kind of short axis of the left ventricle, And normally you should see the wall kind of more snappy than this, more contracting better than this, but this actually not really contracting well at all. And he comes in with the heart failure symptoms, and he also comes in with the blood clot because stasis of the blood in the heart here. So there's a lot of complication happen after he's been in VT for a very long time. So during this echo, you look at the ECG while he's in the rhythm he's in is in a VT. And we know right away that VT is coming from the usual spot that we normally see, which is come from left ventricle area that we normally see in the young kid. So he basically in the ventricular tachycardia for 2 months. So look at the heart rate is really fast, 150 for 2 months. The heart dilated and really poor function, having poor function. So the treatment, probably you can give medication orally, but he's too sick. Any medication that slow the heart rate could cause low blood pressure. So he ended up having cardiac arrest while he's admitted in the hospital. So we decided to go and help with ablation. So I just give you an example of when they come to an ablation. So for example, in each case, you kind of plan, right? You read an ECG, you know it's coming from LV. You have to plan to get into left ventricle. So the way to get into left ventricle, there's 2 ways, right? There's aorta or through mitral valve. You have to make decision which one you're gonna go. But in this patient, if you remember, I told you that he was sick, he was intubated, and he was sick enough that he need to have intra-aortic balloon pump. Anyone know the intra-aortic balloon pump, or have you ever seen before?
Yes, we'll learn about it.
Oh, okay. So it kind of help enhancing the blood pressure, by coordinating with an ECG of the patient. So he still needs some help with intra-aortic balloon pump during the time, and it's really huge balloon that's sitting in the aorta. So normally when we try to ablate and go into left ventricle, we try to go in the arterial access from below, right? But in this case, it make it a little bit difficult or impossible to stop aortic balloon pump during the case. So we ended up planning ahead that we just gonna go in and trying to get access from the femoral vein going up the IVC. This is a right atrium, and then we puncture the interatrial septum by the needle, and then we put in the sheet, the long sheet here, and then I can get the ablation catheter up the sheet, down the mitral valve, down the LV, and then get to the spot that creating the VT in this patient. So I put the catheter down, and then this is what we visualize on the 3D mapping picture. Is actually exactly same picture as the fluoro picture that you just saw. And then we find a spot that we interested, and then we could eliminating the VT by just do ablation in this a small area here. And as you see, the signal when we do ablation, the left part here still ventricular tachycardia, and then you'll be able to find the area. This is my ablation signal, really early, really fractionated, really nice signal, and then be able to terminate the VT, just putting the catheter over there. So we put on energy after we able to terminate the VT right here. And this kind of give you kind of morphology of the LV. This is aorta, LVOT, and then the spot that we ablate is on the septal side and in the LV. Yeah. Okay. Is that better?
Yes, thank you.
Okay. Anyone has any question? I know it's really tired learning about this. I'm gonna make sure that I'm gonna do the next one really within an hour, because a lot of time sinus node dysfunction is kind of more detail that you can read about, and not much in practical that you have to go into too much detail. Any other question about ventricular tachycardia that you may have?ยังมีชีวิตกันอยู่หรือเปล่าคะ
ยังอยู่ค่ะ
โอเคจะ break you want to give a break like 10 minutes break ดีไหมคะเข้าห้องน้ำกินน้ำแป๊บหนึ่งแล้วเดี๋ยวมาต่อ sinus node dysfunction น่าจะประมาณชั่วโมงหนึ่งอะเอาเท่าไหร่ดีคะ10 หรือ 15 นาทีค่ะ10 นาที
5 นาที
เท่าไหร่นะคะ
หรือ10 นาทีก็ได้
10 นาทีก็ได้นะคะ โอเคงั้น
ได้ค่ะอาจารย์
ตอนนี้กี่โมง 15:03 งั้น we'll be back around 15:13 นะคะ โอเคนะคะstop sharing ยังไงนะโอเคค่ะงั้นเดี๋ยวกลับมาเจอกันอีกที พร้อมไหมคะฮัลโหลได้ยินไหมคะ
ได้ยินค่ะอาจารย์แต่ว่าไม่ทราบว่าอาจารย์ส่งสไลด์นี้ให้พวกหนูหรือยังนะคะ
ส่งไปทางอาจารย์สุภาวดีอะค่ะได้เนี่ยค่ะหรือถามอาจารย์สุภาวดี
เดี๋ยวหนูถามอาจารย์ดูค่ะขอบคุณค่ะ
ได้งั้นเดี๋ยวถ้าพร้อมเมื่อไหร่บอกนะคะจะรอสไลด์หรือว่าให้เริ่มไปก่อนเลยดีคะ
อาจารย์เริ่มก่อนเลยก็ได้ค่ะเดี๋ยวพวกหนูค่อยตามสไลด์ทีหลังก็ได้ค่ะ
โอเคได้ยังไม่ได้ใช่ไหม
ยังติดต่ออาจารย์ไม่ได้อะค่ะแต่ไม่เป็นไรค่ะ
โอเคได้ อันนี้จริงๆเดี๋ยวขอดูก่อนอาจจะสามารถพูดให้เสร็จภายใน4 โมงได้เพราะว่าsinus node dysfunction มันเนื้อหามันค่อนข้างน้อยอะค่ะแต่ว่าที่ในสไลด์มันอาจจะมีเนื้อหาเยอะนิดนึงนะคะแต่ว่ามันไม่ได้เอามาใช้ใน clinical experience เยอะเท่าไหร่นักต้องใช้คำนี้ว่าไอ้ VT เนี่ยเยอะกว่านะคะโอ เคเดี๋ยวพี่เริ่มเลยแต่อย่าตกใจกับสไลด์นะคะเพราะว่ามันจะดูตัวหนังสือเยอะแต่ว่ามันไม่ค่อยเอามาใช้เท่าไหร่มากเท่าไหร่นะอย่างนี้ละกันโอเค so I'm gonna try to make sure that I'm gonna finish by 4 p.m. And make sure that you're not gonna fall asleep for the whole class. So sinus node dysfunction, I'm gonna go walk through anatomy, physiology, and just give you kind of knowledge about what causing sinus node dysfunction and what important of sinus node dysfunction and recognizing sinus dysfunction from ECG or EP study, and or kind of give you some ideas who in the real life will need a pacemaker for sinus node dysfunction. But like I said, a lot of times sinus node dysfunction is not a whole big deal in the electrophysiology field. It really not giving a lot of big implication for our patient in clinical practice. So concept, sinus node is the top in the hierarchy. Below sinus node will be other cells. So meaning if the sinus node is not there, you're gonna see other cells actually taking over. So really easy. If you remember this concept, when you are dealing with sinus node dysfunction, your EKG, you're not gonna see sinus P wave. You're gonna see P wave coming from somewhere else, really strange spot. Or you're gonna see just junctional rhythm because you're not having anyone working up there. Or you're gonna see really bad situation, you're gonna see ventricular rhythm, which is really bad. Normally you're gonna see more narrow rhythm without P wave called junctional rhythm. So hierarchy system give you an idea who's gonna start working first, which is sinus node first in a normal circumstance because it can take over everyone. Because sinus node cell has automaticity, which is generating the rate, or the highest rate, which is 60 to 100 beats a minute. And other cell can create the rate that's slower than sinus. So sinus always take over. Who faster will take over other people, pretty much. We already went through cardiac conduction system. So sinus activation, up top, top to bottom, and right to the left. And then you can interpret P wave axis on an ECG just to kind of give you an idea that P wave originating from the sinus area. And give you kind of picture of when you look at these cells in term of you know, electrical activity of each myocyte. We divided the myocyte into atrial and ventral myocyte, and the other group of cell called automatic cell, which is sinus and AV node, will have a different type of electrical potential when you look really in detail of electricity of those muscle cell. So what different is the SA node and AV node has automatic leaking of the voltage ion. So that can create the up sloping of the action potential graph. So that can create auto stimulating itself. So that's why we call it automatic cell. On the other hand, those atrial and ventral myocyte cannot itself having creating itself action potential itself. It needs these cells to come and trigger a first depolarization phase, which is action potential. So the difference between the two, this cell can be automatic, but this cell cannot be an automatic cell. So that's what we explain. There's a constantly of the influx into the cell that creating leaking of the influx of the ion, and then can create its own action potential. And if you have more steep of the curve, that's mean when you having a faster rate of the depolarization. When you are giving medication that blocks the channel, for example, beta blocker, calcium channel blocker will block calcium influx. That can cause kind of slower the slope here. That can be creating the slow heart rate of the heart, pretty much. Anatomy, if you look at the anatomy, you can see the sinus cells lying in the groove between SVC and the right atrium here. Inside, that's an epicardial space, but inside the heart, that's kind of go inside with the area called crista terminalis. But actually, more recent data showing that the sinus node cells actually could be extending down to the IVC area here as well. Just remember, the higher group of cell, really high up top, responsible for during sinus a high sinus rate or during faster heart rate. You can go through these slides by yourself. It's more like detail-oriented type of slides. It took me a little bit time to do this slide because it's a lot of wordings and stuff. But like I said, at the end you understand that a clinical implication really small for those sinus node dysfunction itself. Blood supply really important to understand as well, because when you see patient with right coronary artery MI, or you're going to see patient comes in with bradycardia, because the right coronary artery actually supply SA node and AV node. So those patients that comes in with MI that involving the right coronary artery, you probably can see with the bradycardia, AV block, because majority of people supplied by right coronary artery for SA node and AV node. Nerve that supply SA node and AV node, it's a balance between vagus and sympathetic trunk. So vagus nerve causing everything to slow down in SA node. Sympathetic trunk causing everything to go up pretty much. And when you say sinus node dysfunction, you can interchangeably saying SSS or sick sinus syndrome. You can say anything. That's mean your sinus node is really sick. That's mean you have an abnormal automaticity conduction, and that can cause no activity or less activity of SA node. So between automaticity problem, so that's mean the disease inside of SA node, but with the conduction problem, actually SA node is actually working well, but actually could not conduct out to the atrium. Sometimes we call sinoatrial delay or block or failure to transmit the impulse. But overall, clinician, you cannot gonna tell whether it's a automaticity problem or delay conduction. You cannot really tell. You can tell only sinus node dysfunction on a big picture. Cause, we all gonna end up having sinus node dysfunction if we're gonna live 90 years of age. It's a age-related issues, and if it's happened before the old age, there's something could be hitting the SA node before. Trauma, other problem, for example, high vagal tone, with some of the disease that can infiltrate the SA node, or patient that underwent heart surgery that can create the injury to SA node directly or scarring around AV node directly. And that's a laundry list of cause of sick sinus syndrome. There's so many things, intrinsic, extrinsic. And you probably can hear people talk about atrial arrhythmia in sinus node dysfunction. What does it mean? So when you have sinus node dysfunction, I kind of trying to understand that that's mean when you have no one controlling the atrium. It means that everyone, no teacher around, so student can be playing around uncontrollably. So atrial tissue actually in the uncontrolled fashion, because you don't have sinus that control them. So when you don't have sinus node that control them, so they ended up having its own activity called atrial tachycardia or atrial fibrillation. So that's a reason why you see atrial arrhythmia occur really frequently when you have patient with sinus node dysfunction. It always happens together. That's we call tachy and brady syndrome. Also, if you have atrial arrhythmia for a very, very long time, sometimes you ended up with atrial arrhythmia for a very long time, sinus node will be sleeping because someone taking over them for a long time. So it's kind of interchangeably between sinus node dysfunction and atrial arrhythmia, and overall people will say, oh, tachy-brady syndrome. So ended up, you need a pacemaker, you need an anti-arrhythmic measures, medication or ablation to help with tachyarrhythmia. Okay. Again, vagal tone, like I mentioned, can cause a problem in sinus node. Excessive vagal tone, for example, in some patient with excessive vagus stimulation, what we call carotid sinus syndrome, hypersensitivity. Some people can just turn their face to the other side and then they can faint because carotid body on the neck area really sensitive. Or if you are looking at well-trained athletes, they train well enough that they can have very slow heart rate. Sometimes they can have heart rate resting in the high 40s or 50s because they are having really high vagal tone to SA node. Or some other thing else, for example, patient having nausea, vomiting, or they bearing down in Valsalva maneuvers can creating high vagal tone to SA node. That can cause transient sinus node slowing down. So that's mean when you have adrenaline, you have sympathetic drive that comes into play, you can try to stimulate this SA node to work again. So clinical manifestation in the real life, when I, as a physician, seeing this patient, rarely that I will see the patient having symptoms. Mostly patient won't, sinus node dysfunction alone, they will be fine. But if they have symptoms, definitely because of the slow heart rate, definitely they will have a problem with exercise intolerance. They could have the history of syncope, or they could have a tachycardia, like we mentioned, tachy-brady syndrome as well. So symptoms, wide range, tired, up until syncope or palpitation because tachycardia intermittently. Again, very uncommon. Sometimes when we see wide range of the symptoms. You can go through this slide later again if you have it. And again, over and over again, AFib and sinus node dysfunction comes together. And people quote a number that the incidence could be up to 5.2%. So that's mean if you are helping to control the atrium by pacing the atrial lead to help pacing an atrium, definitely you bring back the teacher to the school so the student could be uncontrolled again. So you trying to pace the atrium in the orderly fashion and faster. So that's you kind of take over an atrium again. That's going to prevent these people to come fast in the disorder way. Not only sinus node dysfunction are problematic, but people that, especially in the older people, sometimes when you have sinus node dysfunction, you can develop also AV block up to 10% as well. So when you are dealing with patient with sinus node dysfunction, you have to look carefully whether the problem is only in SA node, but you can have a patient that have two problems at the same time as well. So just to realize that when you have slow heart rate, it's not only a SA node problem, could be an AV node problem that happen together as well. So diagnosis, clinician use ECG, clinician trying to use exercise testing, maybe use some medication, maybe trying to record the symptoms by using some of the other maneuvers we can show later. You can try to capture to get more information during the time that patient have normal activity at home. For example, putting the ambulatory ECG monitoring, or we call Holter monitoring, trying to monitor any symptoms occur or trying to monitor how the heart rate do during the day and during the nighttime. This carotid sinus massage, I never done it before. I don't know anyone will want to do it to the patient or go to do it to the patient, because you have to tell, oh, I'm gonna massage your neck, and that can bring you to the floor and you can collapse to the floor. Is that okay for me to do? And they will say probably no. It's kind of scary, you know. Sometimes they really worry that because carotid hypersensitivity syndrome, theoretically they're trying to do it just to kind of enhance the carotid sinus activity and see if you can make that patient faint or not. ECG feature, if you remember the hierarchy that I talked about, the hierarchy, if you don't have sinus, you probably see some pause of those sinus, and you probably see some of the activity down below sinus, which is ectopic atrial cell or junctional rhythm, or we talk about tachybrady syndrome. We talk about carotid sinus hypersensitivity, meaning with the activity of changing position of the neck, you see really pause of the heart rate. So ectopic atrial, junctional rhythm, ventricular rhythm could be taking over. So I'm going to kind of go through some example of each of the categories of the sinus slowing down. This is not a sinus node dysfunction, but just a description of the sinus slow down a little bit. Sinus bradycardia mean you have the sinus rate firing at rate of slower than 60. You still have the origin, that the P wave that coming from sinus. The clinicians just have to see the cause of the sinus bradycardia from externally, whether it's medication or disease that can cause sinus bradycardia. Sinus pause or sinus arrest, meaning you have a very long period of pause without any activity of the P wave. They describe that the pause could be up to 3 seconds in the normal people, but if it's more greater than 3 seconds, you have to be worried that you're having a sinus node problem. This is an example of the ECG. All of a sudden, you don't see the P wave. That's called sinus pause. And so sinus pause, actually, when we're gonna go through some of the feature of what type of pause. But again, this feature doesn't really implicate anything much. It just, you can describe ECG, and people around the world describe the same thing, but it doesn't really give implication to the patient that much. It just give you nomenclature, how we call it, pretty much. So if you have a pause that not equal to the PP interval here, so meaning the pause here 1860 millisecond, you add up your cycle length, the normal cycle length, the two cycle length was 1400, right? So it's not really comes into PP interval multiply something. So that's mean it's just a pause itself. It's not an exit block. If it's an exit block, it will come probably pause at 1400, like around 2 times here, meaning you're supposed to have one P wave that disappear, but the other one P wave just reappear again. So that's called exit block. But if just a plain pause. You can pause any number, but not related to your preceding sinus rhythm or following sinus rhythm. Example sinus arrest, again, nothing occur. So like I trying to go to, it's sinus exit block, meaning you have actually normal sinus node, but actually you have something around sinus node that blocking impulse of the sinus to come out to the atrium. For example, you have some surgery in the past that you can create scar around the sinus area, example. So it's just a nomenclature and how people call it around the world. When you see that ECG, it doesn't really give you much of the implication that much. You can have, when you learn about AAV block, you have first degree, second degree, third degree. Sinus node also has the same thing. You have first degree AAV block, meaning you have activity from the sinus down to the atrium, just delay, but you still have one-to-one conduction down to the atrium. Second degree AV blocks depends if you have Mobitz 1, meaning you will have some activity to the atrium, and then all of a sudden you just have pause. Same as Mobitz 2. And third degree AV block, meaning you don't really see the sinus coming out from the activity to the atrium at all. So detail about first degree AV block, first degree exit block. It doesn't really mean much because you can't really prove it clinically or in EP lab. It's too difficult to find the SA node and too difficult to find to measure SA node to atrium time. So just learn that it's there, but it's not really give much implication. Second degree SA block, it actually gives some excitement a little bit because you probably can diagnose from looking at the ECG. So this is a key feature that you want to diagnose. So it's really confusing when you're trying to understand these type of ECG, but they said maybe a look at PP interval, it's gonna come shortened before it drops. So when you see this feature, you're gonna say, oh, it's because of the SA block, second degree SA block, SA exit block, type 1 or Winky-Bach block. So it comes like this. SA node firing to atrium, more delay, and then finally it blocks. But what you see in a real life, you see only here. You don't see this area at all. It's not like AV block that you're going to see PR interval, right? So what you're going to see here is you're going to see P wave interval come close, a little bit closer. P wave come a little bit closer before disappear. So it said, oh, exit block type 1, second degree. PP shortened before block. Type 2, you cannot really say much because it's gonna be all of a sudden just pause, basically. So all of a sudden just pause. So one SA disappear. But again, if you measure from area of the pause, you could be a multiply number of the previous PP cycle length. So that's going to give you an idea that, oh, because of only one P wave disappear, so the next P wave just come on time. So it's called sinoatrial exit block type 2. Third degree, really no impulse conduct to the atrium, pretty much no sinus activity at all. No one knows unless you study the SA node time to atrial time, which is we don't do it, like I said. Okay, so this is more excitement. Again, we talked a little bit about Tachy-Brady syndrome. This is what you're going to see in EP lab, and this is what you're going to see patient comes in a lot more frequent for pacemaker. Prolonged period of pause and also in intermittent history of Brady alternating with atrial arrhythmias, like I said before. So Tachy-Brady, you can have very long pause and you can have episode of tachycardia. So tachycardia, and then you have termination of tachycardia abruptly, and then you get a really long pause. So these patients will come in with palpitation and syncope. So you want to control palpitation with medication, that slow heart rate, you have to make sure you have pacemaker ready in this patient. So sometimes when you have patient with sinus node dysfunction, you could have patient with atrial standstill. What does it mean? So that means that atrium become fibrotic, or it's become diseased enough. There's a scar tissue around the atrium, so atrium doesn't really contract anymore. SA node is all gone. So it's like a World War. You have the bomb, injury, all the people in the atrium, so it's all dead, pretty much dead tissue. So this is more terminology when people describe, oh, you probably have sinus node dysfunction because you have chronotropic incompetence. So we are going to talk more about when patient comes into our practice, and then we suspecting that that patient and that ECG probably implies a sinus node dysfunction, right? So what we do, sometimes we bring them to give medication to make them walk, to make them run, and they could not have ability to increase sinus rate. So that means that patient fit with the criteria of chronotropic incompetence. So that could imply that the sinus node is not healthy enough to able to go up to create the rate that appropriate for that age. We talk about carotid hyposensitivity. When you do carotid massage, you get super long pause, and that patient can get syncope. Remember the other term, sinus arrhythmia, not a sinus node dysfunction, but it's actually normal. So when you run an ECG and you see the patient with sinus rate not regular, but slow down during expiration, get a little bit faster during inspiration. So that's some respiratory sinus arrhythmia, ups and downs depending on respiratory cycle. So called sinus arrhythmia. When you see this term, not a disease, and we don't have to do anything. The other fancy term called ventriculophasic sinus arrhythmia. What does it mean? So it's mean that we see some varying of the sinus rate. So if you walk through with me here, you are having patient with third degree AV block here, but you see sinus activity here, somewhere here, and somewhere here. If you measure PP interval, normally you should have sinus rate that really constant. But again, when you have sinus rate not constant, it could be because you have respiratory variation, like I said, in sinus arrhythmia, or it could be because of this type of arrhythmia in the sinus node called ventriculophasic. What does it mean? It's mean that after contraction of the ventricle, they believe that you have a better blood supply to the sinus node artery, and you're gonna get a better or faster coupling of the P wave here. So when you measure PP between this P to this P, just right after the QRS, you will get a shorter PP interval when compared to other PP interval that not having QRS in between. It's a fancy term, doesn't give you anything. It just for you to understand that there's a term out there and people may talk about this and you will understand what they're talking about. That's pretty much. Okay. Pharmacologic testing, like I said, if you want to do more testing, you do exercise, you do medication. You can give medication to a patient, especially in EP lab, and see if you can drive the SA node or not. If you can drive it up, so that means there's some tissue in SA node that you can drive it up. However, in the real life, we don't usually do this routinely unless you bring the patient to EP lab to look for something else. You can give medication in EP lab and trying to understand if they respond to these medications or not. Propranolol or other testing, meaning you're trying to see if you can enhance the sinus node problem. They probably put these lists in the book, but we never do it in a clinical practice. Adenosine, maybe not to do it in a clinical practice, but we use adenosine sometimes in an EP lab in the case of the tachyarrhythmia instead. So give you kind of list of the measure or things that we use to detect Holter monitor like we talk about, or in patient that you worry that they may have a prolonged pause, you can have them wear what we call event monitor. However, with the event monitor, patient sometimes can be, patient has to be conscious to do this. So meaning when they start to have winded symptom or they feel pre-syncope, fainting a little bit, but still conscious, they can put their hand on the chest. But if they are already unconscious, probably this is not the tool that you should use. If they cannot perform event monitor, sometimes putting these implantable loop recorder maybe be able to detect the prolonged pause on a loop recorder. EP study, what we do for these, sometimes I personally never have to bring the patient in regularly for sinus node check, but only bring to the lab just to look for both maybe sinus node and AV node and look for indication for pacemaker pretty much. And also you want to look for if the bradycardia because of the sinus node plus AV node or not, because you're going to have to pick and choose what type of pacemaker you want to use in those patients, whether it's going to be atrial pacing alone or you want to do dual chamber pacing. That's when you want to bring patient to the lab to look in detail whether it's from problem in the SA, AV, or bundle branch, for example. So what you want to do is you want to do the term we call sinus node recovery time. So what we do is we pacing in the atrium faster than SA node. So we're trying to overdrive the atrium. And after 1 minute, so depends how people want to do it. Pretty much you want to pace for a very good period of time. And then you pacing for example, 60 seconds, and then you stop. When you stop, you want to see how sinus node responds after people stop taking over. So there's a number. So after you stop pacing, you want to look for a pause. If you have a pause less than 1.5 seconds, that still could be normal. If you want to use the corrected number here, you can use corrected sinus node recovery time, meaning you use that number minus sinus cycle length of patient. If it's less than 550, that's considered to be normal. So this is a number you use. So the whole thing, the whole lecture, when you get to EV lab, this is the only number we do in the EV lab. So that's why really small implication to use on a patient, but just memorize that for sinus node, when it has to come to EP lab, you want to look for a sinus node recovery time. So when you pace, and then you stop pacing, and then you look for when the sinus node will re-emerge again. So in this patient, sinus node recovery time is really long. It's 1.6 seconds. So give us some implication that patient could have sinus node dysfunction. Okay. Secondary pause, what does it mean? Meaning when you induce tachycardia, when patient in the tachycardia for a long time, and then you just stop pacing, or you suddenly stop tachycardia. So your sinus node, if you remember, I talk about atrial arrhythmia for a long time. When it stops, sometimes sinus node need time to re-emerge again. So what we call a secondary pause. But with the secondary pause, this can cause hypotension or syncope. So that can cause symptoms to those patients. So this term I mentioned earlier, if you are fancy enough and you have a tool, you can measure sinus node activity to the atrial activation. So that's called sino-atrial conduction time. We will never do it in the clinical practice. It's more fancy of the research. So that's if you want to really know if it's exit block, which type, and you want to learn more in detail molecularly, but not really give a good implication that much. We are coming to almost towards the end. Indication from pacemaker. Always remember indication, patient has to have sinus dysfunction with symptoms. Usually you have symptoms or you have tachybrady syndrome that also has symptoms. That's when you bring patient to the lab to do a pacemaker in those patients. So in summary, sinus dysfunction overall, I think for all of you to learn implication to bring patient to EP lab, you should memorize that there's a really important implication in patient with tachybrady syndrome and who should get pacemaker for sinus dysfunction. Any question? I know it's a little bit kind of descriptive subject, a little bit maybe sleepy a little bit.มีคำถามไหมคะ Any question?
ตอนนี้ยังไม่มีค่ะ
โอเคค่ะคือ sinus dysfunction อาจจะง่วงหน่อยนะคะ โอเคค่ะแล้วได้hand out หรือยังคะ
ได้เรียบร้อยแล้วค่ะ
โอเคค่ะได้ค่ะงั้นก็จบเลคเชอร์นะคะ ถ้ามีคำถามอะไรฝากอาจารย์อีเมลมาถามได้นะคะยินดีนะคะแล้วก็ไว้เจอกันตอนน้องๆมาฝึกงานที่ศิริราชนะคะ
โอเคค่ะอาจารย์
ค่ะไปพักผ่อนได้ค่ะทุกคนน่าจะหมดแรงค่ะ
ขอบคุณมากค่ะอาจารย์
ขอบคุณค่ะ
ขอบคุณ
สวั
ค่ะ
ส
อา
ดี
จาร
ค่
ย์
ะ